Step into the illuminated dark room where I shine a light on breast-related topics and beyond. I'm Dr. E.P. McCurley, a general radiologist with over 20 years of experience in breast imaging. In this podcast, we'll explore the diverse and unique patient journeys, share insights, and empower listeners with knowledge. Join me as we dive into candid, real conversations that illuminate the path to better breast health. I'm so excited to have Dr. Peiris on my podcast today. So I'm going to start off by introducing Dr. Peiris. Dr. Lashan Peiris is an Oncoplastic and Reconstructive breast and general surgeon and assistant clinical professor within the Division of Surgery at the University of Alberta. He specializes in the surgical management of breast disease and total breast reconstruction. Dr. Peiris graduated from Imperial College School of Medicine, London, and undertook his surgical training in London and throughout the south of England. During this training, he developed a keen interest in managing both benign and malignant disorders of the breast. Dr. Peiris is the clinical lead of the Comprehensive Breast Care Program, which provides education and navigation to all Edmonton Zone and Northern Alberta patients with benign and malignant breast issues. He's also the surgical site lead for the Cross Cancer Institute. So thank you so much for agreeing to be my guest.
Well, thank you very much for having me. It's very exciting, and I'd like to commend you, Dr. McCurley, on all the work you're doing in promoting empowerment and knowledge for women who are going through breast cancer. So well done. It's great.
Oh, thank you so much. I appreciate that. And you are doing just as much, if not even more. I spoke to Nico, so I know that you guys are super busy. So the fact that you agreed to do this, really,
It's my pleasure. It's my pleasure. Anytime.
Okay. So I always start this with asking people what their name is. Just being African, names have meaning. So, and like I said, you're the only Lashan that I know. So what does Lashan mean?
So I honestly don't know the answer to that question. My parents are from Sri Lanka, which is a small island in the Indian Ocean, very near to India. So there is a lot of cultural and geographical similarities between India and Sri Lanka, but it's a very different kind of people. And so my last name, Peiris, is I think it probably originated in Portugal, because the Portuguese actually colonized Sri Lanka hundreds of years ago. So there's lots of Pereiras and Fernandos. In fact, my wife's maiden name was Fernando, which is very Portuguese. Yeah. But Lashan is I only have maybe come across one or two other Lashans just by accident on Google or Facebook, and I honestly don't know there's a meaning. I think it's just something I think my parents are maybe expecting a girl, and they probably thought they could call me a girl's name, and so this was like the compromise that sounded slightly male.
Well, it makes you unique, and unique you are. So, okay. Well, let's go ahead and ask you, what was your journey to medicine and then to surgery? Let's start with that.
So I'm the first doctor in my family, or I was the first doctor in my family when I qualified. My dad was a chemistry teacher. My mum worked in admin. And I've always had a keen interest in science. We had a really inspirational family doctor when I was growing up as a child, and he was also from Sri Lanka, and really nice guy, very knowledgeable, always very welcoming, and he was almost like a role model for me. And so I knew from a very early age medicine was probably where I was heading, and I was very kind of focused and one-track minded. And then when I got to medical school, I had a really good friend that was always very focused on surgery, and we used to hang out together a lot. And I remember just randomly I was sitting in a lecture room in medical school one day, and one of my friends who was sitting next to me said to me, "You've got a surgeon's hands." And I said, well, that's interesting. No one's ever told that to me before. And so that kind of probably worked to my subconscious a little bit. And then, when I qualified and I did a bit of internal medicine and a bit of general surgery definitely motivated me, and being in the operating room and fixing things really, really appealed to me. So I think I like the very physical nature of surgery, and being able to make an instant change in somebody's health. That really appeals to me.
Okay, that's so cool. Because you know what, I knew right away I wouldn't do surgery, because when I did that, I did surgery with one of the surgeons, and he wanted me to take over, and I was like, oh my gosh, this is so not me. So yeah. Okay, that's interesting. It's amazing how people that are around you tend to influence what we
Oh,
do in the
absolutely.
future,
I had a
right?
few inspirational mentors over the years when I was a resident. And the guy I worked with right at the end of my residency, his name was Dick Rainsbury. He was
Hmm.
very inspirational. He was a former president of the Association of Breast Surgeons in the UK. And he was in his twilight years as a surgeon and as a consultant. And he said to me, well, if you hang around, I'm sure you can take my job. And we kind of
Oh,
job shared for a little while. And so if there's anything challenging or any difficult breast reconstructions, I just call him in and we do it together. So it was a really good introduction to consultant or staff life. And even to this day, we keep in touch and I always
that's
bounce
nice.
ideas off him. So I agree. I think having a mentor and having an inspiration in the field that you want to go into really does
For
mold you, I
sure.
think.
Yeah, for sure. And that was in the UK.
Yeah. Yeah.
So how did you make your way from the UK to Edmonton? And when did you come to Edmonton? Because I remember.
Yeah, I've been here for 7.5, almost 8 years now, come February. And so I thought London was the center of the world. When I was growing up in England, London is the place to be. And you think you're going to live, work, and die in London. And then you kind of step outside London and do a couple of like residency training jobs outside London. And you realize actually London isn't the be all and end all. And then I
Yeah.
met a girl from Edmonton, and she was over there on vacation, and we kept in touch, and we did the long distance thing for a while, and we ended up getting married. And to cut a
There's
long
always
story
a
short,
girl. There's
yeah,
always a girl.
that's what people tell me. Yeah,
There's
that
always a
when
girl.
when people ask me why I'm in Edmonton, when I mention that my wife's from Edmonton, it's like, oh, so that's
Oh,
why.
yeah, for sure. Because, from UK to Edmonton, okay,
Yeah,
that totally makes sense.
yeah.
Okay. And did you do oncoplastic surgery before coming here?
Yeah. So, interestingly, one of the things we've published on here in Edmonton since I came is that there's a huge difference in training between becoming a breast cancer surgeon in the UK and Europe, to be honest, and becoming a breast cancer surgeon in the US. And
Okay.
that huge difference is not related to the pathology, because breast cancer is the same no matter where you live. It's really related to how we manage it surgically. So, for the longest time, general surgeons have taken breast cancers out with a lumpectomy or taken breasts with a mastectomy. But
Mhm.
really, it's about the long term quality of life that we leave these patients with. And since 2002, the surgical curriculum in the UK has acknowledged that if you're going to be a breast cancer surgeon, you need to be trained in certain procedures which historically have been in the territory of plastic surgery. So, to name a few, breast reduction. So, nowadays, for the last 20 years, breast surgeons in the UK have been trained to do a breast reduction for breast cancer. So, if you come into the clinic with a breast cancer and you have a double D cup breast and you've got a 5 centimeter tumor, well, historically, your surgeon will be saying to you, you have to have a mastectomy. And from a quality of life perspective, that's pretty hard. I mean, it's a big ask to ask, especially a younger woman, to have a mastectomy and have a D cup breast on one side and nothing on the other. So nowadays, if you have a large volume breast, the simplest form of oncoplastics is essentially combining the lumpectomy with the breast reduction, and that way we are A, preserving the breast, B, preserving the shape of that breast, and C, preserving symmetry. And by a surrogate measure, that therefore preserves long term quality of life and satisfaction. And one of the papers we've published since I've been here in Edmonton is we've given women a quality of life questionnaire before their breast cancer surgery and given them a quality of life 3, 6, and then 9 months after their breast cancer surgery. And we've shown
Mhm.
that quality of life paradoxically actually improves after breast cancer surgery, which is a far cry from 50 years ago when women were left with, to be frank, pretty awful and nasty cosmetic outcomes. So because women are surviving their breast cancer, we as breast surgeons have to really be mindful of what we're leaving these women with, which you could forgive our predecessors for not really thinking about, because in the
Yeah.
1950s, 1960s, prognosis wasn't as good as it is now.
Yeah, and things are changing. Yeah, I remember that because I remember before you came, 5 centimeters. That number seems to stick in my head as if it's anything over 5 centimeters, it's a mastectomy,
Yeah,
and it was a learning curve for even when the technology saw, oh, okay, so it's 7 centimeters, you're gonna do a lumpectomy, what?
yeah.
So yeah.
And we
So
really push the boat out now. So it not even so you're right in that this size criteria of 5 centimeters and over, we really try to break that dogma now, because it really comes
yeah,
down to one thing, which is the breast tumor to breast size ratio. So if you have a 4 centimeter tumor in a double A cup breast, that's a different scenario to a 4 centimeter tumor in an H cup breast.
yeah,
And yeah, and if you have multifocal disease, so more than one cancer in the same breast, where historically a surgeon would say you have to have a mastectomy, we're now pushing the boundaries with who we can conserve and who we don't. And obviously, we are led by the patients. Patients have a very individual and personal relationship with their breasts. They come to us at different points in their life, different points in their relationship, different points in their childbearing years, and so we have to take all of that into account. So
Yeah.
it's fascinating and it's extremely rewarding because I said this before, you get let into a very little window of a woman's life
Hmm.
that sometimes they don't even share that with their nearest and dearest, and yet you get to
Hmm.
explore what their wishes and what their anxieties are, which is quite rewarding at the end of the day.
Yeah, that's cool. Yeah, I was listening to a podcast that was reviewing the highlights of the 2024 American Society of Breast Surgeons in Orlando. I'm not sure if you were there.
Yeah, no, I wasn't there, but I watched it from afar.
Yeah, and one of the things they mentioned was that there was a focus on oncoplastic surgery
Yeah.
being, surgery being performed by surgeons. So that's why I wanted you to explain what oncoplastic surgery was, because the surgeon that was talking about it, she was like, I have to make sure to write down to get my certification. So
Yes.
that's why I figured their training is a bit different.
Yeah. So, I mean, my colleagues wouldn't forgive me for saying this, but I would say that North America is slightly behind Europe when it comes to
Hmm.
oncoplastics. There's still this territorial divide, which is we're slowly and steadily breaking down, I must say, here in Canada, where you have general surgeons doing the cancer surgery and plastic surgeons doing the reconstructive surgery. But there is some overlap now where we don't have to include a plastic surgeon. Yes, we have a very good working relationship with our plastic surgeons. Yes, we have to play to our strengths. If there's ever a patient that I feel would be better off under a plastic surgeon, then we do a combined case. But there are a certain number of patients who we can see and we can say, well, we can manage your cancer and the cancer will come first. But at the same time, we can actually leave you with a good cosmetic outcome, be it from oncoplastics, which is a lumpectomy, but rebuilding that defect, like I said earlier, with a
Hmm.
reduction, or even doing an implant based breast reconstruction or doing some kind of flat based reconstruction. So, again, breast reconstruction is something that we do after a mastectomy. It restores and maintains your breast shape, even though you haven't got a
Hmm.
breast anymore, you've had a mastectomy. We can maintain breast shape and therefore quality of life. So there are certain reconstructions that we breast surgeons are increasingly able to do, but still we're very far away from that being standard of care here in Canada. So just to give you some context, there was a paper published in the UK about 5 or more years ago now showing there's over 200 surgeons in the UK who are general surgeons who
Hmm.
will do their own implant reconstructions. That number in Canada, to my knowledge, is three. There's only three surgeons
Oh,
around the entire country who will do their own reconstructions, and two of them are in our office. One of
look at
them is in
that.
Ontario. So we have a long way to go. We just appointed our first oncoplastic fellow here in Edmonton.
Okay, I was going to ask that about the training.
Yeah. So
Who's the
hopefully,
other
then,
oncoplastic surgeon?
I beg your pardon.
Who's the other oncoplastic surgeon?
So we have Dr. Lesniak here. So Dave
Right.
Lesniak is one of our partners in my office. He did
Okay.
his fellowship training in Paris. So he was
Oh,
there
okay.
for a year and he came back with all of these tools to his belt. Dr. Rajai Soniku is also an oncoplastic trained surgeon from Ontario. So she did the Toronto fellowship. And so she
Yeah.
came to us with the ability to do oncoplastics and breast reductions for breast cancer. There's three oncoplastic surgeons in our office here in Edmonton, two of whom do their own implant reconstruction. But we
That's
also have two very high volume plastic surgeons in our hospital as well. So for things like abdominal free flap reconstructions, where we move the fat from the belly up to rebuild the breast, or for the more complex implant reconstructions, we always will have a low threshold to involve them as well.
okay. Yeah. That's amazing. And I'm glad that you mentioned the numbers because I I want the listeners and especially people in Alberta and in Edmonton to know what amazing talent they have there. I mean,
Well, that's very kind. It's very kind,
it
and
is
I think
amazing.
I feel as though being in the right place at the right time helps. I feel as though we caught Edmonton and Canada on an uptick. I think that oncoplastics is here to stay. It needs to become standard of care. We're very passionate about it here. We've organised educational courses for not only
Hmm.
our provincial surgeons but for surgeons from all around Canada to come. And I think now that we've appointed our first fellow, this will now disseminate slowly out into the communities. And so my hope and my dream is that one day this will be standard of care wherever you are in Canada.
Oh, that's lovely. I love that. Now, I want to talk about some of the highlights at the conference, but before we do that, I also want to talk about a program that's unique to Alberta, and that's the comprehensive breast care program, or since I'm in Calgary, it's the Calgary Breast Health Program, right? And
Right.
I know you're the clinical lead of this.
Yeah.
One of the reasons I wanted to talk about it is, I was part of the BIRADS 5 pathway when we
Yeah.
started it.
Yeah.
And unfortunately, now that patients can see their reports online, or, my Alberta ID,
Yes. Yeah.
oftentimes they see that macrobirads 5 before they've talked to their primary care physicians, right?
Sure.
And then they're like, well, what is this, right? And you try to explain it to them. It's I sit on the the quality assurance program, and we talk about it as being something that's really amazing, especially Edmonton. I know Edmonton was one of the leaders in that program, and then the other places followed. So if you could just kind of talk about it, your role in it, and what it is for patients, I think it's just amazing.
Yeah, I can't take any credit for the comprehensive breast care program. This was set up by my predecessors, Dr. Kelly Dabbs, and followed by Dr. David Olson, who's
Dave,
now
yeah.
moved out to Nova Scotia. And so the idea of the comprehensive breast care program is the problem that they foresaw was when a woman has a breast lump, she goes to her family doctor. Her family doctor organizes a mammogram and an ultrasound. If there is an obviously suspicious, i.e., breast cancer on that
Hmm.
mammogram and ultrasound, that report then goes back to the family doctor. The family doctor then has to organize a biopsy. The patient goes back to the radiologist for that biopsy. Then the biopsy report goes back to the family doctor. So it's very disjointed. And then finally, the family doctor refers to a surgeon. But by that time, weeks, maybe even months have passed. So in order to streamline that process, the comprehensive breast care program is a team of nurse navigators, who I lead. The nurse navigators are taught about breast disease. They know how breast cancer presents. They know how to work up breast cancer. So now if a radiologist like you sees a high risk lesion, it looks like a cancer, it looks like it's highly likely to be breast cancer,
Yeah.
they will send that report as a BIRADS 5 lesion not only back to the family doctor, but they'll alert the comprehensive breast care program. So now our team of nurse navigators kick into action, and they will look for that pathology report. And if, as we suspect, which 90 plus, maybe 95% plus percent of the time it is a cancer, then they
Hmm.
will already be calling that patient, taking them through that diagnosis, facilitating a referral. Now, we still need the referral from the family doctor. We don't do anything outside the remit of the family doctor because they are the quarterback. They're the people that
Of course.
will coordinate the care. But we will reach out to the family doctor's office and say, okay, we'll receive the BIRADS 5 referral. Please, can we have the referral? And we will facilitate a referral to surgery. So it just streamlines the whole process. Nurse navigators are great because they will call the patient before the surgical consult. They'll call the patient after the surgical consult just to make sure there's no questions. They'll call before the surgery, after the surgery. So we have these milestone events in the comprehensive breast care program where the nurses will reach out at least 4, maybe 5 times around the time of their diagnosis. And anecdotally, the patients really do benefit from it. Now, they are given the choice, and every now and then we meet a patient that says, well, actually, no, thank you. I don't want to get these phone calls. And so we won't
Oh,
navigate those patients. We'll just keep an eye and follow their
okay.
pathology, make sure everything gets done. So people do have a chance to opt out. But for the majority of people, when I talk to them in the office, they really do appreciate those phone calls.
Yeah, for sure. I got this booklet, Your Journey Through Breast Cancer Surgery, and it's information for patients and families, and that's through this program. And there's so much great information in there. I love that. I was talking to one of the patients yesterday about it. How soon do patients get to see you as a surgeon?
Yeah, so that's a interesting question right now because historically, when we got a referral from the comprehensive breast care program, we would see them within a couple of weeks. That was
Hmm.
our wait time between receiving the referral and seeing them in the clinic. Now, with the retirement of a few breast surgeons here in the city, with the movement of our lead to Nova Scotia, that wait time has been slowly and steadily increasing. So myself, my colleagues have been opening up extra clinic time just to keep up with the numbers. So now that wait time is around 5 weeks for us to
Yeah.
see that patient in our consult. So there's a lot of anxiety. Understandably,
Hmm.
when a patient's diagnosed with breast cancer, A, it's just an anxious time in their lives. But B, they're also anxious because they're now being told they're waiting about a month to see a surgeon. I reassure my patients, I say, look, it's sad that we've waited so long to meet, but at the end of the day, long term prognosis is not any different, any worse by a delay of a few weeks to see a surgeon. So yeah, right now we're booking out at about 5 weeks. When Dr. Rajai comes back from maternity leave, we are. She will obviously see more patients. We're recruiting a new breast surgeon to the zone, so we'll have another breast surgeon in this office as well. So all those things will serve to reduce our wait time. So we are going through a bit of a dip right now, where we're
Yeah.
seeing patients waiting a bit longer, but hopefully it won't be very long.
Yeah, that was one of the things. Thanks for that answer that the patient yesterday said, because she's like, well, in 4 weeks, I told her about 4 weeks.
Yeah,
She said, is it gonna like grow? Is it gonna change? And I figured as much. It's not gonna make too huge of a
yeah.
difference. But yeah, I'm glad you acknowledge that
And patients,
patients.
hopefully are reassured by the fact we do triage patients. So Breast
Okay.
cancer, as you know, is a spectrum. And I say to patients, on one end of the spectrum, you just have precancerous change, cells which haven't even invaded yet. They can't spread around the body. And so this is called DCIS.
Mhm.
On the other end of the spectrum, you've got these nasty, bulky cancers. Maybe they're in the lymph glands already. So when we get these referrals, we do try and see those nasty cancers quickly,
Perfect.
accepting that it's not great for the precancerous patients to wait, but at least we know those patients definitely will take months, maybe even a year or two for them to really change their prognosis.
Okay, that's good to know because she did ask that, with if it's terrible, will she be called? And I said, yeah, I bet you
Yeah.
that there is a triage process. Okay, that's awesome. Thank you for that. Okay, let's now go back to the highlights. We talk about risk factors for breast cancer. Everybody wants to know how to prevent it, what to do, and I know that one of the things mentioned was that apparently BMI, diet, and alcohol are less important now in terms of breast cancer risk, and more so there was a focus on stopping smoking and exercising. What are your thoughts on that?
So it's interesting because we talk about primary preventions, which is reducing a woman's risk of getting breast cancer in the first place. And then we talk about secondary prevention, which is reducing the risk of a recurrence, reducing the risk of getting a second breast cancer after they've had their treatment for breast cancer. And so you're right, there are various risk factors that we explore with patients. We look at their family history, we look at whether there's any close family members who've had breast cancer, especially at a younger age, because that might alert us to do a genetic test to see if they have a high risk mutation, such as the common ones are BRCA1 or BRCA2. In
Right.
the absence of a family history, there are other risk factors that we do look at. So I do routinely ask women in my clinic, how much do you drink? How much do you smoke? And we know there's good data that excessive alcohol intake is a risk factor. So I'm very open with my patients to say, look, you do not have to live like a nun. Having a glass of wine every now and then is fine. In fact, it can be quite therapeutic to sit down with a glass of wine at the end of the day and just shoot the breeze with your loved ones. So
Yeah.
sometimes patients come into my clinic and they say, I stopped drinking, I've stopped eating sugar. And I say, look, you can have a cake every now and then if you want to. It's not going to bring your breast cancer
Yeah.
back. So we have to be slightly open minded about it. Now, yes, if they come in and they say they're drinking a bottle of wine every day, I will say, look, you are probably increasing your risk of having a recurrence drinking that much. So you don't have to be teetotal, but you should just bring
Hmm.
down your alcohol intake a little bit. The same goes for BMI because about 75 to 80% of breast cancers are estrogen receptor positive breast cancer, which means their cancer is being driven by their estrogen levels. We
Hmm.
know that high BMI women, because they have more adipose fat, will inherently have higher estrogen levels. So you have to be quite diplomatic how you say this sometimes, but I say, look, keeping in shape, being active, being physically active, we know will improve your long term prognosis.
Right.
Smoking is a funny one. If you'd asked me 15 years ago if smoking was a risk factor for breast cancer, I'd say, well, we don't really have any good trials or studies looking at that. We know smoking is a risk factor for lots of cancers, lung cancer,
Hmm.
bladder cancer, heart disease, lung disease. But for specific breast cancer, I didn't know of any studies, but there have now been some good studies published showing that smokers have a higher risk of breast cancer than non-smokers. So in the
Hmm.
league table of risk factors, I wouldn't say it's in the top five, but it
Hmm.
definitely is a risk factor. But the way I script it with patients is, look, if they're a heavy smoker, this has far-reaching consequences on all kinds of things in their life, not only
Right.
their fitness for anesthesia, but their underlying risk of having a heart attack, having a stroke, and yes, breast cancer now as well. So
Yeah.
I would say that certainly BMI, certainly alcohol, lifestyle, but also smoking has lots of far-reaching consequences.
Yeah. And there's moderation and moderation. I mean, I
Oh
have
yes,
diagnosed people that are plant-based
yeah,
Ironman, Iron Women athletes, right? And
yeah,
we've got to live. We have to live,
yeah,
right? Okay.
yeah.
Yeah, that's good to know. That's what I teach as well.
Great.
Okay. Now, another thing they talked about was genetic testing.
Yeah.
And it's my understanding that they said that just about everyone should have it. I'm keeping in mind that this is the States, but people, and it's social media, people are listening, and they're more informed than in the past.
Yeah.
So I kind of want to know what your thoughts are about genetic testing. Does it depend on age? Does race play a factor?
Yes. So this is interesting because the American Society of Breast Surgery published a guideline a few years ago, and that guideline was very broad. It said every woman diagnosed with breast cancer should have a genetic test. Now
Right.
we know that the access to genetic counseling, especially here in Canada, is very limited. It's a finite resource. So if we now say we're going to test every single woman that walks through our door genetically, there's just no way we can keep up with that. Now there
Exactly.
are non-AHS private companies that will offer genetic testing. And so we have a very strict list of criteria here in Alberta. And there's either women that can have what's called mainstreaming genetics, which is almost like a fast track genetic test. They can get it done within 4 to 5 weeks, or they can have just a regular routine genetic test, which right now takes about 1 to 2 years to come back. So we have to screen these women because what I say to patients is genetic testing is great in some circumstances, especially when you check some boxes off in the history. So, mum had
Mm.
breast cancer at a young age. My sister had breast cancer at a young age. Mum, in fact, had ovarian cancer and breast cancer. Then I start to worry that maybe there is a mutation. But the converse is true. If somebody comes in their 60s or their 70s, this is their first cancer, no one in their family's had breast cancer, then the risk of them having the pre-test probability, we call it, of them having a mutation is actually very low. So then why would they go through testing? And it is a double-edged sword because yes, it's great if we find a BRCA1, BRCA2 mutation because there's lots of research, lots of data. We know exactly how to counsel those women. But 50% of mutations that come back are called VUSs, which stands for a variant of unknown significance. So now I'm saying to a patient, okay, you have this mutation. We don't know what it means. We don't have any research. We don't have any guidelines. So now you just have to live with the fact you have this mutation. We won't make any decisions for your breasts based on this mutation. Yes, you'll go into a registry. So if in 5 years or 10 years it gets downgraded and we now know it's benign, you'll get a phone call. Or if a study comes out saying your mutation codes for colorectal cancer, you'll be called and told you should have some colon screening. But that can be quite difficult sometimes for patients. Now you have like a dark cloud hanging over your head. You've got this
Yeah.
mutation, but no one can tell you what it means. So I don't think it's fair for a woman to have a genetic test unless they know what they're letting themselves in for. And it comes down to everything, right? It's just informed consent. They need to know what the advantages of this test is, but also they have to know what the disadvantages are. And again, in my practice, I have patients that say to me, well, you know what, I think I would struggle if I was told I had a mutation and no one can tell me what it means. So in
Yeah.
fact, maybe I won't get the testing. So there are some drawbacks to just universally testing every single breast cancer patient. So again, like we said earlier with the risk factor piece, I think it's just moderation. We just have to
Yeah.
select out the patients who we think are high risk for mutation because then it would influence their management.
Mhm. Who are the women that qualify for that fast track?
So there's a criteria. I actually keep it on my desk. It's right next to me, actually. So it's any woman under the age of 35. So under
Okay.
35 should not get breast cancer. So if you're under 35 and you get breast cancer, automatically you get the fast track test. If you have a so-called triple negative breast cancer, so triple negatives mean your estrogen, progesterone, and HER2 receptors are all negative. Well, we know in the BRCA1, BRCA2 populations, triple negative breast cancers are a bit more prevalent. So if you
Right.
have a triple negative breast cancer, it doesn't mean you automatically have the mutation, but it just means you hit these criteria. So if you're under 65 with a triple negative, you can get tested. If you
Mhm.
have two breast primaries, so I'm going to see a patient today, I'm going to call her, and she has two different kinds of breast cancer in the same breast.
Mm.
So she's under 60, so now she meets criteria for testing. If you have a cancer in 1995, then you get a cancer in 2005, and they're two completely different cancers, and you're under 60, you will get qualify for this test. If you're a male of any age, so we know that men do get breast cancer. For every 100 cancers we diagnose, one will happen in a man. So it's
Right.
very unusual. So if a man gets breast cancer, we would explore their genetic testing as well. And then breast and ovarian cancer in the same woman, breast and pancreatic cancer in the same woman. So, like I said, I have to consult my cheat sheet every now and then.
Yeah.
But they're very strict with the what we call mainstreaming criteria.
Yeah. That's good to know. Yeah. And that's one of the reasons why I wanted to do this. I listen to these podcasts, and there's such a difference between how we practice in Canada versus the States,
Yeah,
and it's the genetic testing for everybody. I was like, wow. I
yeah,
mean,
yeah.
I don't know how that's going to happen.
I mean, just
And
on that note, sorry to interrupt you. If you just
okay.
on that note, the one of the huge differences we see, which in fact is really good for the public to know, is every week when a patient comes in to see me with breast cancer, at least 4 or 5 times a week, I get a request, please just take both my breasts away. They've got a single
Yeah.
cancer in a single breast, and their request is, please just do a double or bilateral mastectomy. And we spend a lot of time with these patients. It's not fair to just say no. Equally, it's
Mhm.
not fair to just say, yes, of course we can do that. So the data, the research will show if you're average risk, so there's no strong risk factors for a genetic mutation, then you will live just as long with a single mastectomy as you will with a double mastectomy. So then why essentially double your risk of complications, double your risks from surgery? There's actually no gain to be had. So I get it. When you're told you got breast cancer, there's almost a reflex that goes off in the back of your head
Take
saying,
it off.
take it off.
Yeah.
But that is, and we have to piece out what's the emotional response, what's the anxiety response, and what actually is a long-standing response that's going to be there forever. And so we spend a lot of time in our clinic saying to patients, look, I get it. I understand why you want to have both your breasts removed, but removing a healthy breast is not going to change your long-term survival. You will live just as long if you just have a lumpectomy, for example, and radiation treatment. 9 times out of 10, when I have this conversation with patients, they kind of do calm down a bit and they do realize that, in fact, the research is there to show you do not have to have a double mastectomy. In the States, we see that the rate of double mastectomy has been climbing every year. When you look at
Interesting.
that data in Canada and in the UK, we see the rate of double mastectomy is low and has remained low for the last 20 years. So something is off. Something is different between Canada and the UK and the States.
Yeah.
And there's lots of theories as to why that may be the case. There's papers published as to why that might be the case. But the party line, the evidence-based decision should be that you should not have a double mastectomy for a single breast cancer.
Yeah, it would be interesting to do a study down the road to see the survival
Yeah.
in those that have had double mastectomies versus in Canada, those that have had,
Yeah.
oncoplastic. That would be interesting to know.
Yeah, we have some data comparing. We have some good historic data showing that women that just have unilateral breast surgery, a lumpectomy, or mastectomy, in fact, the chances of them developing another cancer is actually very low, less than 1%. So we're now acting upon a risk of less than 1% with a mastectomy, where the risk is what, 5 or 10% of having a bleed, having an infection, having a wound breakdown, having some kind of
Right.
psychosocial issue. So it's not without its risk having a mastectomy. And like I said, patients are sensible. When we have this conversation, they hear about surgical risk, and that does concern them more than this theoretical risk that maybe they'll get breast cancer again one day.
Yeah, that's good. Yeah. I'm sure you've heard of Olivia Munn.
Yes.
Yeah, so she in the States, she's a celebrity, and
Yeah.
whenever celebrities get breast cancer, it's all over the place, right? And
Yeah.
one of the things that's really big with her right now is this risk assessment, right?
Right.
Which, interestingly, anyway, I did look into her story. I know she had a mammogram. I think she even had, and she went through genetic testing, and everything was okay. And then when she had that risk assessment, her lifetime risk was high, and then she had an MRI, and lo and behold, she had cancer, and then she had, the mastectomy. So now, and I do know that the American College of Radiology says, like, if you are, say, Black woman or an Ashkenazi Jewish woman, to have a risk assessment by age 25. Do
Yes.
you see that done in Edmonton, Alberta as a whole?
So we have a great facility here in Edmonton, which a lot of patients don't know about, called the Allied High Risk Breast and Ovarian Cancer Clinic. So this is a group of physicians, one of whom is a retired breast surgeon, one of whom is a medical oncologist, and we surgeons are actually getting more and more involved with that. I've actually been in that clinic a few times. It's
Okay.
run out of the Royal Alexandra Hospital. It's run every Thursday and Friday. And what they do is they see women who are perceived as high risk for breast cancer, be it on family history grounds or, like you mentioned, on race grounds. So
Yeah.
yes, I think we're pretty good at highlighting the Ashkenazi Jewish piece. I think even from medical school, both you and I know that it was having into us that this is a risk factor for many cancers.
Right.
Where I think we lag behind the US is in identifying other racial minorities that might be high risk for breast cancer. So you mentioned Black and African American women. We
Hmm.
know from lots of studies and lots of evidence that, unfortunately, sadly, they do carry a worse prognosis than their white American counterparts. We don't know why there's this racial disparity. Maybe it's socioeconomic, maybe it's genetic. We just don't know, but we do know from observational studies that sadly there just is a difference, there's a divide. One of our residents did a research study out of Harvard, and she highlighted this as well. She showed that there were racial disparities between breast cancer outcomes. So a lot of work back in the UK. One of my somebody I know out there is a breast surgeon, and she does a lot of work trying to highlight this, mainly for the South Asian population, the Indians, the Pakistanis, the
Hmm.
Bengalis. There's a huge population in the UK, and it's just about education. They just don't know about screening mammograms. They don't know
Yeah.
about risk factors. So I think a lot of work does have to be done here in Canada on highlighting those disparities here. We obviously have the First Nations and the Indigenous population as well to think about, and they historically, as you know, just have really poor access sometimes to good medicine and good care.
Yeah.
So I think a lot of work does have to be done on some of the racial minorities here in Canada to try and bring up some of their disparities so that they're more in line with their counterparts.
Yeah, no, that's absolutely true. You said a lot of things that I completely agree with. I was in Ottawa, like earlier this year at the House of
I
Commons.
saw that. I saw that. You got slapped with
Yeah,
them. Yeah.
yeah, as a Black woman, and I come from a family of 8 children. 7 of us are girls, and then my mom. So
Right.
there's 1 in 8,
Yes.
and you see this, and I'm just, I hate to say this, but you're kind of like, when,
Yeah.
and I think, at least in Canada, we have free healthcare. There's a screening program. So it troubles me, one, when women, especially racialized women, don't know the data. They don't know that this is a problem.
Yeah.
And also the buy-in to get mammography.
Yeah.
There's so many people that come in, "Oh, I just want an ultrasound,"
Yeah.
and
Yeah.
so yeah, that's why I'm fighting for to get it down to 40. And the new guidelines, interestingly enough, I don't know if you saw it, is in the 40 to 49 age group, it did actually say that Black women have a lower incidence of breast cancer, but a higher mortality. But they
Yeah.
left it.
Yeah. Yeah.
It's still at 50. I'm like,
Yeah.
it doesn't make any sense to
I
me.
know.
And so sometimes I think, okay, is this just a study? Do you actually see this in your practice that racialized women have,
I
presents
do.
earlier
I
and
do. I do. I see it in definitely in racialized women. I see it in the indigenous group as well. Sadly,
Mhm.
these are patients that just for lots of social reasons just fall by the wayside, and by the time we get to see them, they're just slightly more advanced than others. We do definitely see an inordinate amount of ethnic minority women who come in and they have slightly more advanced breast cancers. We treat everybody the same, so we'll still get them
Mhm.
in. Well, obviously, once they're diagnosed, they will have conventional treatment, but it's just that window between onset of disease and diagnosis that's probably wider in racialized women than non.
Yeah. Why do you think racialized women present later?
Oh, it's a tough question. I honestly don't know. I think it depends on the racial group, right? I think we're seeing a lot of changes over the generations. So, me being a second generation immigrant, my parents immigrated from Sri Lanka to England when they were in the 60s and 70s. So, myself, my brother, we were born in the UK. So, we've had the advantage of being brought up in a society where we were treated the same as our colleagues, whereas our parents' generation, I feel probably who did come over, maybe did have some discrimination. And so I think as the generations pass, I think we probably will hopefully optimistically see some convergence of the ethnic groups, that things start to become a bit more equitable across racial minorities. But why it is, I think, is multifactorial. I think it's people coming to Canada from other countries who maybe don't have the same education is the wrong word, but maybe awareness of the
Hmm.
disease and awareness of strategies that we have, such as a screening program,
Right.
to mitigate against the effects of that disease if it's caught early. We know, you know as well as I do, that screening will select out women who want to be healthy. So if they
Right.
want to be healthy and they're proactive, they will go for screening. Whereas patients who don't really know much about their health, like my father-in-law, for example, he takes medications. He doesn't even know what they are. I'll be like, so what are these pills? He says, I don't know. I just take what the doctor gives me. And I'm like,
Right.
what do you mean you don't know? You're taking these medications.
You trust the
So
doctor, right?
yeah,
Yeah,
I
in that
know. So
moment. Yeah.
I think we're moving away from that kind of thinking now, and I think people are more aware and are more educated about their health.
Yeah, I think this is hopefully this generation and the one coming are gonna change things,
Yeah,
make it, let's just talk about it and normalize the conversation,
yeah,
right? And
yeah.
yeah. Okay, yeah. Okay, awesome. Now, speaking of imaging, how easy is it to get, actually no, I'm gonna back up. Mammograms. Do you ever do a surgery without having a mammogram on a patient?
I can probably count on maybe two fingers over the past 15 years how many women with breast cancer I've operated on without a mammogram. So I think I've heard you guys, the breast radiologists, talk a lot. And I know still in 2024, mammography is the gold standard. It's the best imaging tool that we have for breast
Yeah.
disease. And so we've got to take it with a pinch of salt because we all know that mammography is not 100% sensitive. We have to tell patients, I'm sure you tell patients every day, even though your mammogram is normal, it doesn't mean you don't have breast cancer. And so we do have to be
Right.
breast aware. And so sometimes patients ask me, well, what should my daughter do? And I say, well, as long as they go for their screening mammograms when the age hits, and B, they are breast aware. So if they find the lump, they don't panic, but they also don't ignore it. Give it a month. If it's still there, go and see your family doctor and get some imaging. I remember vividly when I was a second year resident in the UK, a woman came in with a fungating, ulcerating, ignored breast cancer. And so I went down
Oh,
to Emerge and I saw her and I called my boss and I said, look, I'm going to admit this lady, but it's awful. She's got this fungating cancer. And he said to me, you don't understand, in the 50s and 60s when he was a resident, this was a monthly occurrence. Women used to
mm,
just ignore their symptoms. There was a stigma, there was a taboo around breast cancer.
yeah.
And so finally they'd come in when it was awful. Now in 2024, thankfully, we empower women, right? We there's so much social media and media highlighting breast cancer and early detection that it's
Hmm.
very unusual now for us to see women coming in with ignored breast cancers. So to that to your question, I think women generally will accept mammography. You probably see more women than me because I don't see that denominator of
Hmm.
women that are fearful of mammograms, and I understand it. I mean, I've never had a mammogram, but I've heard lots and lots about it. I know it's not a comfortable test to have, but still, you just have to come and sit in my office once or twice a week to see the number of women whose cancer was detected early. It may be high grade, it might be HER2 positive. You know that within a year, within 18 months, that would be a big cancer in the lymph nodes, perhaps even stage 4. So yeah, I will always sing the praises of screening, and even reducing the age of screening, as you guys are plausibly, you should be applauded for what you're doing, trying to reduce the age.
Yeah, I thank you so much for saying that, and I hope people take this to heart. It just breaks my heart each time I see, and I am seeing that younger and younger women,
Yeah,
30s, 40s, and so that, yeah, that is heartbreaking. Now in Alberta, we do have an advantage. You mentioned mammo's not perfect, but if we have a category D or high C, they are not average risk. They're a little bit more than average risk. So we do supplemental screening. Alberta is
yeah,
one of the places that has the ABUS,
yeah.
and or handheld ultrasound, and it's kind of built into part of your assessment. So
Yeah.
that's good.
And that's great. And again, I don't know the denominator, but I regularly see women who had a normal mammogram, but then they had an ABUS detected cancer. And
Mm-hmm.
so the value, I think, is always, like I said, I don't know what numbers are needed to screen to get those those women that I see. But for those women, it was a game changer, because if not, their cancer would have gone undetected because they just
Oh,
had a
for
mammogram.
sure. Yeah, I
Yeah.
just had a lady that she had dense breast, and you didn't see it on the mammogram, but it was right under her nipple. That's where all
Right.
the lymphatics
Yes.
converge. And I'm like,
Yeah.
she had an ultrasound, and that's how we found it. And I'm like, this is a life saved. And she was in her
Yeah.
40s.
Yeah.
So that's
Yeah.
great. You mentioned when you examine yourself. So self breast exam value or no?
So this is a big difference between my previous life in the UK and my current life in Canada. So in my previous life in the UK, I used to actively and explicitly tell women once a month after your period's over, just feel your breasts.
Hmm.
And you don't have to do it every day. You don't even have to do it every week, but just once a month, just feel your breasts, and you can just feel the soft tissue around the nipple. And if you find a lump, again, don't panic because most lumps are benign, but go see your family doctor after a month if it hasn't resolved. Here in
Hmm.
Canada, the public health doctors will say that breast self-examination doesn't change long-term prognosis. So whether you examine yourself or not, it doesn't change your prognosis from a breast cancer. So they take a very different view. They do not recommend that women should examine themselves. They say it causes undue anxiety. My personal opinion is that really sells women short. I think that
Hmm.
women are intelligent enough to know when something doesn't feel right, and they know no one knows your breasts better than you. And so if
Exactly.
you feel as though one day something's not right, then what's the worst case scenario? Is you go in, you have a scan, and someone reassures you, actually, this is fine. Maybe it's a few weeks of anxiety. That's true. But at the end of the day, every now and then, maybe we do find something that is meaningful and we have to treat. So my personal opinion is that breast self-exam is actually a constructive step. I think it empowers women to actually take hold of their health and seek out help earlier rather than later. But the public health opinion is that we should not be encouraging it.
Yeah, and unfortunately, the task force itself too also says don't do self breast exams, don't even do clinical breast exams, even don't do
Yeah.
supplemental screening for density. So it's good to hear that. I feel the same way too. There are a lot of young women, a huge percentage of young women that find lumps themselves,
Yeah.
and come in
Yeah.
for assessment. Yeah.
Yeah.
Now, one of the things they mentioned in this meeting was the use of MRI. They said that MRI
Yes.
is overutilized, I believe they said.
Yeah.
What are your thoughts on that? I mean, in Canada, obviously, there's an access issue.
Yeah.
For me, when I see there's some cancers I see, like if it's a lobular and if it's infiltrative and I'm not getting a good sense of the size, I will put it in my report, do an MR just to figure out extent of disease, especially if
Yeah.
it's a young person. So I just kind
Yeah.
of wanted to get your thoughts on that.
Yeah, and again, I think we always talk about America and how things are different. And when I go to the American Society conference that you mentioned in Orlando this year, but previously when I've gone, it's interesting how MRI is just routine workup sometimes in breast cancer in
Yeah,
the US. It's just part of their triple assessment. They get mammogram, ultrasound, they get an MRI if they have
yeah,
breast. And we don't, A, like you said, we don't have the resource here to do it. But B, as you know, MRI also, like the genetic testing, is a double-edged sword because we sometimes do go down this rabbit hole of, oh, there's some enhancement in the other breast. Oh, we've got a cancer in one breast. Now we have to biopsy the other breast. So we used to, it shouldn't be a joke, but we used to say this in the UK that MRI stands for mastectomy rate increases because there's good data
I've
that
never heard that.
there's good data that if you do an MRI, you're more likely to do a mastectomy, but there's no data that actually MRI improves long-term prognosis from breast cancer.
Lots of
So I
false
agree.
positives.
Yeah, I agree with you. I think there is only very specific, very select instances when I, as a surgeon, would want to say, okay, I think we should get an MRI here. And I think lobulars are one. No, lobulars are sneaky. You know as well as
Hmm.
I do. You see a little bit of architectural distortion and maybe ignore it, or maybe do a biopsy, and then we find the lobular cancer. So
Right.
it scares us as surgeons, especially if a patient wants breast conservation, if they want a lumpectomy, then I have a vested interest in knowing, is this larger than the mammogram, than the ultrasound is leading us to believe. So definitely lobular cancers if they're having a lumpectomy. The other small group of women, it's not a very big cohort, but women in whom there's discordance. So the ultrasound is saying
Right.
this is 2 centimeters. I do a physical exam and this is 5 or 6 centimeters. And
Okay.
that's happened a few times in my practice where I haven't done an MRI and I've approached this with a lumpectomy and I get into that breast on the day of surgery and I can tell this is way bigger than the ultrasound led us to believe. So I think that's a valuable tool for those women. And I just recently upstaged a woman who had a 2 centimeter ultrasound detected grade 2 invasive carcinoma, did the MRI, and all of a sudden it's multicentric. So
Mm,
I've saved her having 2 surgeries and we can now just do one. Over and above that, I think we obviously talked about the high risk women who have high risk screening if they're
yeah.
BRCA1, BRCA2. I think there's a value to MRI there. But no, I don't think going down the same roads as the US where we incorporate it into just our semi-usual workup is going to be of any benefit to most women.
Yeah, I agree. I again, I still see a bunch of women that mammogram declined. They want to use MR for screening, and then
Yeah,
now you find all these little 5 millimeter, six
yeah,
millimeter things, and
yeah,
what do you do with them? Now you're starting to follow,
yeah,
and we've missed the opportunity to find calcifications that are
yeah.
pre-cancer, right? So
Yeah.
it's
And
it's
also
interesting.
from a systematic point of view, I just got an email this morning from the head of DI at the Cross Cancer Institute saying that they have done something like 360 more CTs in this quarter than they did last quarter. And the same
Oh,
probably goes for MRI. And there's only a finite number of radiologists at each center that can read these MRIs. And so
yeah,
what if we start doing more, the people that really need it are now not going to get their MRIs in a timely manner. So there's so many knock-on effects to just increasing how many MRIs we're doing.
yeah, for sure, I agree. Clips. I
Yes.
know that obviously in Alberta, a lot of the breast imaging is done in private settings. The HS doesn't pay for the clips, but you may be surprised that there are, before I even open a clip, and sometimes I've made a mistake and opened it, but some women will say, no, I don't want it in my body.
Yeah.
How important is a clip to a surgeon if there is a finding?
It's very important, especially for the smaller lesions. So sometimes we find that radiology are doing vacuum biopsies, so taking a bit more tissue than a needle biopsy would take. And for the small lesions, there's every chance the lesion could be completely removed or completely obscured now on conventional imaging. So now we're coming to do the lumpectomy. We
Mm,
actually have no idea where the lump is. The radiologist on the day says, well, the lesion's been removed, so we don't know where it was. And so that can be very difficult. So leaving a clip at the time of biopsy, I think, is imperative because it's the only way we know for sure where it was. In our patients that have chemotherapy first before surgery, well, that chemotherapy can shrink the cancer and it could disappear completely. So again, we just don't know where that cancer was, especially if a patient wants a lumpectomy. And I know once in my practice over the past 15 years, a clip wasn't left in, a patient had a complete response with their chemo. Now we can't see where the tumor was. And so sadly, now we have to say to them, well, the only way to approach this now is with a mastectomy. And she was fine with it, but it doesn't leave a very good taste in the mouth when you've
Right.
downsized this tumor so effectively. She could have just had a lumpectomy, but now we have to do a mastectomy. So clips in that scenario, I think, very important. At the time of surgery, when we do a lumpectomy, I always leave a clip in the breast. So we leave the clips for the radiation oncologist so they know exactly where that tumor bed was, because those patients will get whole breast radiation, but sometimes they give a boost of radiation to the tumor bed. And so knowing where that tumor bed was is very important. Now, I hear in Calgary that there have been a few cases where women have really taken issue with the fact that clips were left behind and they weren't informed of it. I
Mm-hmm.
haven't come across that in Edmonton more than 2 or 3 times. And I think after appropriate patient counseling and they realize why we did it, they're a bit less anxious about it. What I say to them is if you have your appendix out, if you have your gallbladder out, we leave clips on the vessels. So it's nothing, it's no different to that. They're inert, they don't set off the metal detectors in the airport.
Yeah.
So these
Can't
will
track
just,
you.
they can't track you. And so I maybe 2 or 3 times in my career, I've had a woman that's really desperately unhappy that I left a clip in without telling them about it. But then when I tell them, look, every single woman that we do a lumpectomy on has these clips and
Mhm.
everything I just said, they tend to be a bit more relaxed about it.
Yeah. It's interesting you say that. There is a definite difference between Edmonton and Calgary, but that's a whole other
Yes.
conversation. Now, I do want to ask you this question, which
Yeah.
is we're getting to the end. As a male breast surgeon who primarily works with female patients, what would you say to any woman out there who might be hesitant to seek care from a male surgeon?
So
And
I
what
would.
strategies do you use to make them, have the conversation, make them comfortable?
Yes, I think that's a really good question. I don't think anyone really broaches that with me, really. I've not had many people ask me that question. And I think the first thing to say is we have to acknowledge patients' anxieties, maybe their culture, maybe seeing a male really. I mean, they're already going through a very difficult time in their life, maybe the worst time that they will ever face. To then add into it a gender that they're not very comfortable with is not fair. So any woman that comes to my assistant and says, "Look, is there any female surgeons around?" We do have female surgeons in this city that treat breast cancer. We have 1, 2, 3, 4, 5 surgeons in Edmonton zone who are female. So there's plenty of opportunity for them to go off to a female surgeon. And personally, I have no issue with that. I'd much rather see a patient who's comfortable with me seeing them than have to wade through all of um, the mire of just trying to get them comfortable with me before we get into the whole process of actually examining them and talking to them about their breast cancer. The first thing to say is if a woman prefers to have a female surgeon, there are definitely ways and means for them to have a female surgeon. Secondly, how do I make patients comfortable? I think the first 10 seconds I walk into the room are probably the most important 10 seconds. So I make eye contact, I smile at them, I'll introduce myself, I'll introduce my medical student, I'll make them aware of what I have done leading up to this moment. So I've looked at their mammogram, I've looked at their biopsies, I know their case well. We're going to take a history. I'm going to put you up on the couch here. We're going to do an exam, and then we're going to sit you down and we'll talk. And so they know exactly what the next 45 minutes is going to be like. So I think the women that struggle with a male surgeon are not due to the patient. I think it's because a male surgeon will walk into the room, they might be brash, they may not be very sympathetic, they may
Mm,
not acknowledge the anxiety in the room. And I think that's when the relationship can fail.
yeah.
So haven't had many women that have after my consultation called and said, "Well, I didn't want to be with this guy. I want to have a female surgeon." And I
Well, I
hope
can tell you, I have a lot of your patients. Because we see them; they love you.
well, I
And
can't
I
pretend.
do know firsthand how much time you spend with your patients. So if
Yeah.
anybody's out there listening, like you are amazing,
Oh,
amazing. Your
thank you,
patients
Effie.
sing your
Well,
praises. I
I think it's a two-way street. I think that I can do as much as I can to try and make a patient feel comfortable, but what impresses and surprises and astounds me is just how stoic and how pragmatic and how positive our patients are. And it's really humbling sometimes when you meet somebody who, like I said, is going through one of the hardest times of their life and they raise a smile and they crack a joke and you really
yeah.
get a good rapport with them. And that really is one of the best things about my job is just meeting people who are very inspirational. So yes, but thanks for saying that. It means a
Okay.
lot.
Got less than 4 minutes. Okay.
Okay.
You do this. It's weighty. There's a lot of emotion involved, whether you like it or not. Your husband, your surgeon, your dad. How do you balance? How do you decompress?
So I think the surgical side of things, the medical side of things, I enjoy. And I'll go home in the evening and maybe I'll share a story or two with my wife. And my kids are getting to an age now, they're starting to understand what they do. I'll show them the odd mammogram every now and then. And my 12-year-old will be able to see where the tumor is. And she said, is that
Oh,
right?
the
So she's
future Dr. Paris.
yeah,
Yes.
no, she wants to do paleontology. So I think that should be
Oh,
good.
that will change.
Yeah. So yeah, I think having a supportive family, I think my wife being a surgeon's wife knows that my schedule is all over the place. And so having somebody patient at home who understands that, I think is half the battle. And so that really helps me because if I were constantly racing to try and get home because it would be an issue, I think that would be much more difficult. So for example, yesterday I got home at 7 and they'd eaten already, and I said, oh man, I didn't realize I was that late. And so it was just very relaxed, and we sat down and we still ate together, and it was great. So I think that's fine. I think once that now I've got a few admin and management hats on, that's where the challenge comes, because I try very hard not to organize meetings in the evening. If I have a meeting, we're doing this podcast, I like for it to be during the day because I like
Yeah.
evening time, weekend time to be family time. So that's what keeps me sane and keeps me grounded. Just having young kids, and I've got 2 girls, so I joke I'm the only man in the house, and they're going to be they're
Just
going
like
to
my
be
husband, yes.
yeah, they're going to be teenagers soon, so that's going to be quite interesting. So
Yeah,
yeah, we have some vacations. We try and get away when we can, and that I think is really good for the soul, and it just
that's
keeps
good.
me sane.
Family time is important.
Yeah, for
Okay,
sure it is.
final words, and include in that, where can people find you? Social media too, physically. I know it's a referral service, but
Yeah, I'd say just bear
can
with
I
us. I think
knock that
now is
question in? Like I made 3 questions into one. Did you notice
sure.
that? Okay, cool.
I'd say that's very good. I didn't even notice. Um, So I'd say the first thing I'd say to my patients is bear with us. The first thing I say when I'm booking a patient for their surgery is just don't freak out. Your surgery is going to be probably in a couple of months, but it's going to be fine. Your cancer will not grow. It won't spread within those 2 months. Yes, the more nasty cancers we get in sooner. But if you have pre-cancer, you have a small low-grade screen detected cancer, it's not going to change in the next couple of months. So the first thing I would say is just bear with us. Wait times are a little bit longer in Edmonton and Calgary than they would usually be. So please just
Mhm.
bear with us. The second thing is I work out of an office. I've got a team. It's not. There's definitely a team behind what we do. So I work with 2 very good colleagues, Dr. Rajai, who's currently on maternity leave, but she's coming back to us in January,
Mm.
Dr. Lesniak. So the 3 of us see the bulk of our patients in our office. We have some great office staff. So my assistant's name is Nina. We've got Chelsea, we've got Kerry in our office who will be the first line of contact for these patients. But our office is called ABSO, which is Alberta Breast Surgical Oncology. We're in the Meadowlark Health Centre. We do rely on a referral from a family doctor. So if you have a breast issue, be it a worry that there's a breast lump, I mean, the family doctor should always be the first point of contact. But if there's an issue, they can refer into the Comprehensive Breast Care Program, and then we can take that referral from the CBCP. We have a website, which people are very welcome to go look at. There's a breast reconstruction link on that website to
Yes.
one of my old mentors that I mentioned, Dr. Rainsbury's website, where he talks about all the different options for reconstruction. So it's a very good resource. We have some links to all the major cancer centers around the continent, like Memorial Sloan Kettering, which is in the US, and the MD Anderson, which is also in the US. But we have lots of links for educational resources for our patients as well.
Okay. Well, thank you so much, Dr. Paris. It
Thank you.
has really been an honor working with you. It's an honor to know you. Thank you so
And
much
you
for what you
too. And
do. You save lives. You really do.
we have a very small cogs and a very big machine. And the nice thing about breast cancer is that it's a big multidisciplinary team, of which radiologists will play an integral role. So, having worked with you in the past, I'm very sad to see and hear that you're in Calgary now. But Edmonton's loss is definitely Calgary's gain, and I can only congratulate you on these educational initiatives that you're taking, because I think it's going to be great for the women of Alberta and further, hopefully, as well.
Thank you so much. All right. Thank you for your
It's
time.
good
I know you
talking
got to
to you.
run, so you
All
too.
right.
Take care.
Take
Thanks,
care. See
Lashan.
you.
You
Bye
too.
now.
Bye.
Bye.
Thanks for being a guest on my podcast, and to everyone that's listened, a huge thank you to you as well. I look forward to sharing the next episode with you. Please follow me on my social media platforms at Dr. Efi Women's Health for upcoming episodes and more. Please note that the discussions and opinions shared in this podcast should not be considered medical advice. If you have any concerns or symptoms, please consult your primary care physician.